Hello and welcome back to A Modern Pharmacist with me, Lee Smith. Now, just because you may not be taking blood pressure medication or you are under the age of 60 doesn't mean that this episode is not applicable to you. If anything, it's probably more applicable to you because there's more time for you to do stuff. And you'll see by the end of this episode of how important blood pressure monitoring is and how vital it is that we manage it earlier on in your life as possible. And it's also applicable to people who are on blood pressure medication because, as you will probably come to understand, in my opinion, that we have been managing blood pressure incorrectly within the UK. The US are in a better place and have a better direction. I still also feel as though they don't manage it properly because of all the other lifestyle interventions, but definitely we are lagging behind in the UK. But before we get into it, I think it's always good to just give a general overview and a baseline physiology so that everyone understands what we're discussing in this episode. So when it comes to blood pressure, we are discussing the pressure that is going through your arteries, veins, and it's going around your systemic circulation. There is a different type of blood pressure, which is related to your lungs, and that is not for the scope of this podcast episode. So when it comes to blood pressure, a lot of people are aware of two numbers. So you've got your systolic and diastolic, and they are your top number and bottom number respectively. So your systolic is the pressure in your arteries when your heart beats. So you would expect that to be higher, which is why usually on the top you will see a higher number. And diastolic blood pressure is the pressure that still exists in between the beats of your heart. So it should be lower, and it's usually linked to systemic vascular resistance. A fancy way of saying how much resistance does the arteries, veins pose when the heart is not beating. Now, that's the basic physiology. And in terms of why blood pressure is so vital, is that we need it high enough so that all your organs stay perfused, but we need it not too high because then you can also cause damage to certain structures. And if it goes too low, you don't get enough perfusion, and then you can get probably just as bad of a complication if it is low blood pressure. So it is, as with all things in medicine, it's about balancing it, keeping it within this Goldilocks zone. And blood pressure, in my opinion, is probably the best thing that we can monitor because it is painless and it's very accessible for a lot of people. So why do I think we are mismanaging it or we are completely behind in the UK? Oh, a few other stats actually, I've not gone into them. I'm trying to stay away from all the stats because, you can just go and read I don't know, a published article and it'll give you all the data. But I believe 1 in 3 adults in the UK have high blood pressure. 1 in 2 adults have high blood pressure within the US. So it is a big problem. These statistics always lag behind. So I think these are from 2024. So I don't think it's slowing down anytime soon. And in my experience within clinics, the majority of people that I speak to have high blood pressure or are on blood pressure medication. And the age is actually, I would say, when I first started within healthcare 10 years ago, you'd be in the 50s would be your average person. Now it is more 40s, late 30s, and it is creeping even lower, which is a scary prospect when you think about it. Now, in the UK, what happens is we have different guidelines to the US, and that's why I keep saying we're lagging behind. And just for context, what we would consider a high blood pressure number, I think this exists across all healthcare, depends on the setting in which you have your blood pressure taken and the age in which you are when you are having your blood pressure taken. So in the UK, once you are 80 years old and above, we relax the targets a bit more because we don't want to run the risk of you having too low of a blood pressure. One, because it'll lead to increased falls. But then also, it's not really in guidelines, but because you are past 80 and the average life expectancy isn't too far away, what is the point in increasing pharmacological treatments when on average the lifespan of the average person is not going to be too much past that 80-year-old margin? And when you are in a clinic, we allow your blood pressure to be higher because, as you would expect, you are more anxious. It is not a relaxing environment. And usually you don't have the right you don't have the right things in place, whether that be time and other surroundings to make it a more representable number as to what you would normally have at home, which is where we would also relax the blood pressure. So we're going to keep this to under 80-year-olds because I doubt anyone over the age of 80 is listening to this podcast. If they are, thank you very much. But if you are under the age of 80, these are the numbers that we are sticking to. So in the UK, if you are going to a GP surgery hospital and you have a blood pressure reading of 140 over 90 and above, we would class that as high blood pressure. And if you are at home, if your blood pressure is above 135 over 85, we would class that as high blood pressure. Where if you swap that over to America, they have their high blood pressure starting as above 120 and stage 1 is 130 as your top number and above, or your bottom number above 80. So where we would consider someone in the UK, and this again, this is all from experience, is if someone's blood pressure, let's say a 55-year-old male, comes in and it's 135 over 82 in the surgery or even at home, we're made up and that's it. We carry on as we are. If you were in America, by the sounds of it, from what I've read and listened to certain podcasts of certain physicians over there, they would be looking to treat that or increase their treatment. So there is a big difference. But why is there such a discrepancy between the US and the UK when it comes to blood pressure control? And a lot of it did change from a study called I think it's a step one. I don't know why it's just completely gone out of my head. But the step one trial, I believe, I will put all the studies below, and they took about 10,000 people, and these people all already had cardiovascular disease. And the reason they picked these was because when you look at studies, you ideally want to see an endpoint in a group of people. So in this case, it was non-fatal myocardial infarction, so heart attacks, heart failure. So in this group of people, you are more likely to see a bad outcome in the next 1 to 3 years than if you were to grab someone like myself or another person who is of lower age, healthy, in inverted commas, and you would probably not see anything for maybe 10, 15 years. So that's why they selected that group of people. And what they did is, out of the 10,000 people, they got a group of people who were in a high intensity treatment group. So they got their blood pressure down to about 121, and the other one were aiming for about 140. I think they averaged 136. Now, for context, in the UK, 136 is still well-controlled blood pressure. 121 is near enough excellent from what we would consider. And between the two groups, you had a 25% risk reduction relative to the other group in not having these endpoints, which were heart failure, heart attacks. And that was over 1 to 3 years. And in these people where they are already being treated and the numbers were still normal or well controlled in the context of national guidelines, that is quite a stark outcome. And it was one of the only studies that I've known of recent times where it was stopped early because ethically it wasn't right to continue it because there was such a disparity between the treatment group and the intensive treatment group. And that is why the Americans changed. They went to tighter blood pressure control. The UK, I don't even know what we did, to be honest. I don't even think anything really changed. I was in university at the time when this was coming out, and the guidelines were pretty, yeah, they were outdated even then. But we haven't really done anything since. And my point is, there is a stark difference between the treatment groups. So we should be aiming for lower levels. Now, obviously, I've got to come out with what is the drawback or the drawbacks of having a lower blood pressure within this group or within this study, is that you can have side effects due to the medication used. So sometimes they use water tablets, so they had electrolyte abnormalities or disturbances. Some people had falls, and some people had dehydration due to kidney issues. So it's not all sunshine and rainbows, but there was a complete difference between 121 versus 136. So my impression of reading a couple of the studies, there is another study, I'm not going to discuss it now. It was done in Chinese people, but eventually and essentially found the exact same findings, is that a lower blood pressure target is ideal for everyone. So in my opinion, there is no ambiguity when it comes to should we have a lower blood pressure target. I think 120 is what we should all be aiming for the top number. The bottom number should be 80. And should you be aiming for that? So let's say for myself, I'm 31. If my blood pressure reading comes back at 125 over 85, should I be looking towards treatment, or should I be trying to do other things? I feel as though, again, the area under the curve concept comes in here, is that for every day, minute, month, year that I leave myself a high blood pressure, it's just slowly chipping away. Again, it's about perception of risk. So I could be chipping away for 20, 30, 50 years and nothing ever happened because for some reason I've offset the risk using something else in my body. But it's how much do I want to play with that risk? And not at this moment in time, because my blood pressures are actually pretty well controlled. They are below 120 when I do them. And I'll come on to the whole point of this is the fact that we need to be monitoring it more because it's so accessible. But I think if it were to creep up and stay at the higher levels, I probably would consider treatment, which again may not be everyone's cup of tea. But when you factor in all the other things that you try and do in your lifestyle, such as sodium in your diet, sleep, exercise, again, I'll come on to. If you've optimized all these and you have something called essential hypertension, which is medical speech for we don't have a clue what's going on, why you've got high blood pressure, which is actually a large amount of people who are diagnosed within the UK and the US. So in them instances, I probably would consider medication because I've seen so many detrimental effects of having poor blood pressure control going forward. And just before I go into the other part of this episode, when you think of heart disease, there's quite a few things that are impacting your risk of heart disease. So you've got smoking, which chemically damages the endothelium, which is the arterial wall. You've got blood pressure, which is mechanically pressing against it, making it damaged from a physical point of view. And then you've got cholesterol, ApoB, which if they are all happening at the same time, so the endothelium's damaged, the cholesterol can go in and then it can start a bit of a riot then. So all these things normally need to be present, minus the smoking. That just accelerates it more. So if you can manage as much risk factors as you can, then it's always a good outcome for you. Now, going on to a big part of this episode, which is I think it's unambiguous that we should be lowering our blood pressure and keeping a close eye on it, regardless of age. And the earlier on that you start, again, it's the same with finance. When you invest, the greater returns because of compound. And basically, when it comes to monitoring blood pressure, it is so easy. Anyone can do it. Oh, there are two ways you can do it. There's the manual way, which is the one where you have a cuff, you have a stethoscope. There's a bit more trickery to that. And you can look at YouTube, there's loads of videos. You can ask your doctor, pharmacist, nurse, whoever you go and see to perform it that way. And I mix between the two. Sometimes I do manual, sometimes I do automatic. From my experience, manual is more accurate and it gives me a lower value than the automatic. And that has been the case for every time I've tested. So I did my automatic blood pressure last week. Bear in mind, I probably was a bit anxious because of the things that were coming up. And it was 131 over 78. And that was in the clinic setting. Whereas if I do the other type of blood pressure, it sits at around 120 over 70-ish. So there is a big difference. So I'm not asking everyone to do the manual one. That is only reserved really if you've got irregular heart rhythms, and it should really be done by someone who's well clued up in the area. But the automatic ones, relatively inexpensive now to buy, £10, £15 on Amazon. You sit there, do the blood pressure. And the reason why I advocate for people to test it at home is that when you do a blood pressure reading in a GP surgery or a hospital, normally, like I've said before, it is not conducive to you being relaxed. You are normally there due to being unwell or something else is going on in your mind where you cannot control it. So naturally, you will be more stressed. Your number will be higher. So to then base your treatment off a number that doesn't represent what's happening for the other 23 hours and 59 minutes of the day seems completely, there's just no common sense there. So even if someone comes in with a reasonably high level, so let's say there's a blood pressure reading 160-ish over 95, I always give the same advice. Go away and do 7 days minimum of morning and evening blood pressures at home, and do it when you are most relaxed. And I will come up shortly with the tips that you should be taking and using when you are doing your blood pressure. But then you get an average over the 7 days, and then from that, there's a good chance that we will get what is happening on a daily basis. Yes, we will be missing out blood pressure during exercise or activity, and also over the night, which, if you have high blood pressure overnight, that can be more fatal and lead to more complications, because ideally you should have lower blood pressures at night. Because if you think about it, you are lying horizontally, there's no pressure to really pump the blood to the brain, which is normally standing above the heart. You are, well, you should be more relaxed. You shouldn't have too much sympathetic tone through the adrenal system. So that is why you should come back with a lower reading, probably 10 to 20% lower than what you would see in a day. And when you are doing nighttime readings that are higher, obviously, if it's the inverse of what's meant to happen, it doesn't normally end with good outcomes. But tips to do for everyone who's doing a blood pressure, because as much as I advocate for people testing it at home, you've got to test it correctly. Otherwise, you can impede your treatment, and you can lead to misdiagnoses or the incorrect management going forward. So the first one is, before you do any blood pressure reading, make sure that you've had about 5 minutes to just relax yourself, be calm. When you are having it taken, your reading, you should never cross your legs, you should never speak, and you should try and be pain-free. You shouldn't really have a full bladder, because all of these things I'm saying would normally lead to an increase in your blood level or blood pressure result. So then it can offset your true diagnosis. So once you've got all them intact, make sure that your feet are against the ground and your back is supported. I actually didn't really know that before this episode. I thought as long as your legs aren't crossed, but your feet need to have contact with the ground and your back with the chair, because again, that reduces your reading. Otherwise, it will increase it. And then once you've done that, you should then put the cuff around your arm, ideally about an inch above the crook of your elbow. And then you should have the cuff, firstly, the right size, because if it's too tight, it'll come back with too high of a reading. If it's too loose, it will be too low of a reading. And a good way to know if it's tight enough is that when you put it around your arm, you should ideally only be able to fit the tips of 2 fingers down there. If you can't fit any more than that, or you can fit your whole hand down, it is not the right size for you. The next one is the placement. So ideally, you want your forearm to be the exact same elevation as your heart level. So if for every inch your arm is above your heart level, your blood pressure will come out as a lower result. And if it's below it for every inch, it will then go up. And when I'm talking going up and going down, it's by a result of 2 every time, give or take, for every inch. If you go below the heart level, it will increase. And that's obviously, when you think about it, if it's going below, it's going to pump harder. Makes sense from a physics point of view. So that's how you take it. Ideally, you should do 2 to 3 readings within a session, and it should be 5 minutes apart. This is where a lot of things are not done correctly, because the average GP clinician appointment, my appointments in primary care are 15 minutes. So if I'm spending 15 minutes by just doing blood pressure readings, I can't discuss anything else, which is medication, diagnosis, whatever it is that they've been booked in for. So that is why usually blood pressure is rushed. It's not taken correctly. And then we don't really have any insights as to what is actually happening with the blood pressure. So I would advise anyone, regardless of age, to go and buy a blood pressure machine and go and measure it at home, so you at least have an idea of what is happening. And then once you've had it checked, I'm saying probably every 6 to 12 months, just have a quick check on it, because I don't want you to be obsessive about it, but then I don't want you to leave it too long, that then, oh, do you know what, you've had a year where you could have optimized this and reduced your risk from heart disease and other things that are happening. Because it's not just heart disease, it's also your kidney, for example. So your kidney has 20 to 25% of each of the volume of blood pumped to it per beat, which, considering how small they are in mass, I think they're like 1 to 2% of your body weight, to have a quarter of your cardiac output is a highly sensitive organ towards any changes in blood pressure. So by monitoring it and managing it effectively as early on as you can, you are offsetting all these risks. So we've discussed why you should have a lower target, but not too low. You should be able to measure it and monitor at home because I've given you a decent idea of what to do. And the next reason is, or the next section will be, how can you optimize your blood pressure with medication if you want to use medication? But the whole point of this podcast is to ideally do stuff without it. And then I will inform you how medication comes into it. So one of the biggest things to move your blood pressure in the right direction, which is lower, is to lose weight. So for every kilo that you lose, obviously up until a point, you will lose, give or take, one off the top number and one off the bottom number. Ways in which you can lose weight, there's normally three methods. So they are CR, DR, and TR. So calorie restriction, dietary restriction, or time restricted feeding. You can pick a mode, you can have more than one, you can have two of them together. So calorie restriction, reduce how much energy you are taking in a day. Your body has to use its stores, which will then make you lose weight. Simple sense. Simple sense. I don't know why I said that. The next one, dietary restriction. So some people may say, I'm not going to have dairy. I'm one of them people due to an intolerance. I used to absolutely love having dairy. I'd have about 4 pints of milk a day, whey protein, you name it, I would eat it. But a dietary restriction there. So for me not having dairy, I don't even think about having any confectionery or any sweet treats because most of them, or I'd say 95% of them, contain dairy. So that's a way to remove excess energy. Oh, I don't know why my voice broke then. And the last one is time restricted feeding. Very popular probably 2 years ago. So the idea is that you can either do alternate day fasting, you can do time restricted feeding in the same day. So you have 8 hours feeding with 16 hours fasting. Again, the whole premise is that you are reducing the energy intake leading to weight loss, and that will improve your blood pressure. Makes a lot of sense. Exercise always fits in, probably the biggest needle of anything to move in healthcare and wellness. Strength training will lower it, not to the same extent as zone 2 aerobic training. They seem to have the greatest movement when it comes to blood pressure lowering. So the studies would say about 2 to 3 hours a week. Zone 2, which is 65 to 75% of your heart rate max, or doing the talk test where you can just about hold a conversation. You can use a lactate meter where it's just below 2, or you can do the breathing test where you can just about do the activity nasally breathing and you are on the cusp of needing to use your mouth to breathe. They will all improve your blood pressure in the right direction. I think from memory, it's a reduction of about 8 off your top number, which are considerable amounts. Sodium, when it comes to diet, quite a mixed one to be honest. Obviously, years ago, the theory behind it is that whenever salt moves from one place to another, it drags sodium. It drags sodium. When salt moves from one place to another, it usually drags water with it. So if you have more salt in your diet, you then drag more water within the vasculature, which makes a higher volume, which would naturally increase pressure. But based on what I've read, it can be mixed. So in some young people, it doesn't really affect them. But then in older people or kidney patients, they may be more susceptible to it. Again, I think we eat too much salt anyway within the Western culture and diet. So I think the UK have 6 grams as sodium chloride as the maximum daily amount. I think we completely surpassed that by a good 1 to 2 grams anyway. And most of salt is contained within ultra processed food. Yes, there are sources such as miso, soy, other healthy foods where you can use it. And that's where your source of salt should be coming from. It shouldn't be coming from ultra processed food. So, diet with regards to sodium, mixed evidence, but reduce it anyway. We're having too much. Exercise, try and do more aerobic. When it comes to weight, try and lose as much excess fat as you can. It will lead to greater blood pressure control. And needless to say, stress, but sleep, I'm going to focus on. So when you start to sleep less than 5 hours, blood pressure control can fluctuate massively. I discussed this on the blood sugar one, and I noticed it myself that when I had less amount of sleep of a night, my blood pressure, well, sorry, my blood glucose control the next day was not even in the same league as it is when I had 7.5 to 8 hours sleep. And we're talking about a 2 hour discrepancy here. When these are looking at 5 hours sleep or less, I can imagine there's the difference in blood pressure and blood glucose control to be off the scale and off the charts. So ensuring that you are getting enough sleep, it seems stupid because it's something we can all do, and because it's not a novel agent, I think a lot of people disrespect it, because a lot of things that we can do for free, essentially, we go, oh, surely that can't be the cure for X, Y, or Z, when in reality it is. It's quite simple, a lot of these things. I'm not saying you're not going to need medication, but you could potentially reduce your dose of a blood pressure medication if you optimize your sleep. And then we go into medication. Since I've qualified, the landscape for blood pressure control and medication hasn't really changed too much. And I feel as though it's because it is a well studied and it's a well cornered area, to be honest. There's calcium channel blockers. So a lot of people may have heard of amlodipine, felodipine, lisidipine. You've got them. Then you've got your ACE inhibitors, so your ramipril, lisinopril, perindopril. And they're the two main classes. If you are then suffering from heart failure, you may go into a water tablet, such as indapamide, which is the most favored one. The older people are still on benzoyl not the best. And then there's newer ones where it doesn't really interfere with the kidney as much. So you've got doxazosin, which is an alpha blocker. These are all really effective medications. Some of them are quite inoffensive. So there's ones where, for example, the calcium channel blockers, if you don't get ankle swelling, there's no real monitoring with them apart from annual blood pressure readings, and quite easy to do. And if I were to go on a form of treatment, I'd probably be more inclined to go down the calcium channel blocker route, because I just feel as though I've seen there's less monitoring with them, there's less things to go wrong. But if you are going to go on blood pressure treatment, there is a hierarchy in terms of what is best suited for you. It's not a one size fits all. So, for example, if you are diabetic, you will go on an ACE inhibitor because it protects your kidneys. If you are over certain ages, if you have certain comorbidities like heart failure, you are more likely to go on certain medications. So it's not a case of you blanket go on to X. It was, when was this now? When I was in university, so about 2014, I think the guidelines changed. It was basically based on your age. So if you were under 55, you had an ACE inhibitor, over 55, calcium channel blocker, whereas now we have a few more metrics where we can optimize your blood pressure control. I feel like that's all I wanted to discuss, really. I'm a bit tired, actually. We had to drive to Preston this evening, and I needed to get this podcast done. So hence, if you are watching this on video, for the last 5 minutes, I've been wiping my eyes because I've got a bit of sleep in them or something. But I just can't stress the importance of blood pressure control enough. It's so easy to do. It's painless. It's inexpensive. It's quick. We get a result. And the good thing is, with blood pressure, you can act upon it. And there's a lot of data in terms of what is the best outcome. And this is regardless of age. You can never start too early when it comes to blood pressure control. And if you look at the stats, it is clear as day, we're all aware that they lead to strokes and all these other horrendous things. So why not control something? I think the biggest answer is because you can't feel it with a lot of things in health until it happens. But I also do it, so I only practice what I preach. And if you got this far, this episode was for informational purposes only. As with all of them, they are not medical advice. However, if you wish to get your blood pressure checked in the UK, you can go to a pharmacy, you can buy it online from Amazon, or if you can manage to get an appointment with the GP surgery, go in and you can get seen by the healthcare assistant or the practice nurse. They're more than helpful and more than happy to do it most of the time. And then you can act upon your results and at least have a baseline. But if you've got this far, I appreciate you for listening and watching, and I will see you in the next one.